So we'll have the next speaker. Dr. Rishi Raj Singh is here. Okay. And sir, Dr. Mahipal wanted to go after this. Can you take the next? You can prepare on the other one. And Dr. Rishi Raj Singh is going to be speaking on unhappy post-cataract surgery patient. What next?
Good evening, everybody. First of all, I am thankful to RSI for giving me this opportunity. My topic is about the unhappy.
Can we have the timer for 7 minutes, please?
Unhappy cataract patients. With the many advances in the cataract surgery in recent years have led to better outcomes and highly satisfied patients. But still we had patients walking in our OPD after the cataract surgery unhappy. And the cause of the dissatisfaction is mainly the blurry vision. And there are various reasons that may cause the blurry vision. The most important one is the residual refractive error. Everything, distant, intermediate, near, night vision can cause the decreased vision in the postoperative period. It may affect the residual refractive error that causes the decreased vision in the postoperative period. So communicating to the patients ahead of the time is very important. It may lead to a 25 happy outcome in the postoperative period because the blurry vision, it can be anisometropia or it may be due to IOL decentration or the PCO. So anisometropia can be easily corrected either with the spectacles or the contact lenses, or maybe sometimes you may require refractive surgery or piggyback lenses that can correct the residual refractive error. But if it is due to the IOL decentration, you may need IOL exchange or IOL repositioning, or PCO that also affects the postoperative vision that can be easily treated with the NDR capsulotomy. Cystoid macular edema, another important factor. Sometimes the anti-segment is perfect, but the OCT macula shows there is the CME in the postoperative period, so that can be easily treated with the NSAIDs and the vision can be restored in the postoperative period. Ocular surface, another important factor. You should look in preoperatively about the patient history, symptoms of the grittiness, discomfort and blurry vision or fluctuating vision. There may be history of systemic collagen vascular disease or associated manifestation that may give you clue about the dry eye disease. So the clinical examination, the preoperative period is also very important. Sometimes debris in the tear film, a low tear meniscus height, or you may require standing with the TBUT or Surmus test may be required in the preoperative period, and look with this superficial punctate keratometry that also affects the IOL power calculation in the postoperative period, causes dissatisfaction or blurred vision. So the corneal sensation, especially diabetic patient, there may be chances of the persistent epithelial defect in the postoperative period that also was the frustration, and the dry eye disease as the elective, because of the elective nature of the cataract surgery, should be treated prior to the cataract surgery. Surgery can be postponed till the surface can be optimized. So there are various ways like the artificial tears, and nowadays cyclosporin is also very effective because it avoids the steroid-induced side effects and can be treated easily. In cases of the aqueous deficient dry eye disease, punctal occlusion can be done after the ocular surface inflammation control. And another important factor is the meibomian gland dysfunction that causes the evaporative type of dry eye disease, and it can be easily treated with topical azithromycin, or if required topical antibiotic steroid combinations can be given. Sometimes tetracycline drugs are effective at least 1 month before the cataract surgery can be started for the control of the meibomian gland dysfunction, and omega-3 fatty acids are also beneficial in the management of lid disease or lid disorders. Like in a patient we operated, vision was 6/6, but patient was not happy, especially during nighttime irritation. Meibography showed loss of meibomian glands, so we treated with the port fermentation, azithromycin, cyclosporin eye drop, and patient was symptomatically better in the postoperative period. Especially in the patients of the uveitic cataract, topical medication should be tapered slowly because there are chances of the rebound inflammation and causes irritation to the patient in the postoperative period, and this is very frustrating to the patient because the inflammation is recurring in this patient in the postoperative time. Evaluation of the IOL. Sometimes the decentration of the IOL, especially in the EDOF or multifocal IOL, causes glare or halos, or in the toric IOL patient, if there is more than 0.5 diopter residual astigmatism even after the 1 week, then there may be chances of the surgical intervention that can cause the restoration of the realignment of the toric IOL. So evaluate the patient. Sometimes dysphotopsia, either positive or negative dysphotopsia, causes the frustration to the patient. So you have to choose between neuroadaptation versus a problem that requires surgical correction. Because in 3 to 6 months, neuroadaptation can lead to disappearance of this type of symptoms. But even after 6 months, the symptoms is persisting, then there may be lens exchange may be required in these patients. So photic phenomena either due to IOL-related issues can be corrected, or sometimes pupillary size cycloplegia bremonitor may be effective in these type of patients. So sometimes patient is not happy in the post-operative period due to near vision. So the demanding patients or the evaluation of the patient in the preoperative period is also very important. Like a patient we implanted with trifocal IOL, but in the another eye the patient was implanted with EDOF IOL. So patient was not happy with the near vision in the left eye. So avoid mix and match of the different IOL technology in patients. So in the post-operative period, in this type of dissatisfied patient or unhappy patient, communication is the key. So use the terminology that the patient can understand, and in this type of patient, listening to the patient is very important, because it is the first step in working towards achieving a patient's happiness following the cataract surgery. So the challenge is providing the best visual outcome with the accurate IOL power calculation on biometry, choose the best IOL material and type, and proper centration and the orientation of the IOL. So in conclusion, patient expectation, and choose the patient wisely. Selection of the patient according to the personality type of the IOL, and preoperative workup is very important before implanting an IOL for a happy outcome in the postoperative period. Thank you.
Dr. Rishi, in your practice, what is the most common cause of an unhappy patient in your practice as an individual?
Sir, I think irritation, MGD, in the post-operative.
So, if that MGD is not picked up on your pre-op evaluation at the slit lamp, then how do you plan to tackle it in your future patients?
Sir, the most important things that we come across in the post-operative period is the irritation, Cuban Rudkin.
I'm sorry, I'm talking about the pre-op checkup of your patient. If you want to pick up MGD, which becomes apparent later on after surgery, how would you suggest that we pick it up in the pre-op examination?
In the clinical examination is very important. So look for the MGD, for the debris in the tear film, or for the irritative frothy discharge at the tear, frothy margins.
That would be obvious MGD. I'm talking about subclinical. If anybody else would like to suggest.
Sorry.
How do we pick up subclinical MGD in our cataract patients?
I think the first thing is that patients have irritation, they have discomfort, and nowadays I think OSA, infrared myopography is the most important thing that you need to do. The other thing is we are not concentrating on the expression test. So if you kind of express it, you can get this secretion that's coming out. So I think those are the important things that you have to pick up. And at times the patients come with irritation also because there is sometimes a cyst formation. So if you puncture that, I pretty often do that in the OPD, the patient gets immediate relief.